Welcome to EuroPCR 2022. My name is Thomas Modine, and I want to discuss with you hemodynamics and minimalistic TAVR. How does it fit in our practice today? We all know that TAVR has become an alternative to surgery with comparable efficacy and safety in high, intermediate, and low risk patients. We also know that hospital stays is something very important. It ranges from 3 to 11 days, but it has a tendency to go lower. Although clinical outcomes continue to improve with lower risk patients and thanks to lower profile devices, there is still no global consensus on what is the optimal strategy to screen, manage, and discharge patients after TAVR. This is why in the couple last years, we had a debate on the minimalistic approach, but there is no univocal definition. I mean, this is different from a center to another, a country to another. And this is why all aspects of care should be taken into consideration and not sacrifice any part of it in order to optimize the results. So the question is, less, is it more? I think this idea fits better with the rapid evolving implantation techniques. We can now do TAVR skin to skin in 30 minutes. We have contemporary technologies that help us go in this direction. Patients are in need and demand for this. It has an impact on the health service delivery and the economy. And we have learned from the COVID-19 pandemic that we have to go faster. But if we want to go faster, we should not sacrifice the efficacy. And one of the biggest concerns still the significant residual AR or parallel leak or mismatch with higher gradient, and the need potentially to trust esophageal echocardiography to assess that. So this is something we want to get away from. In this direction, the Vancouver 3M study is a milestone which has been assessed in different volume centers. It showed clearly, as highlighted by the red column, that in lower risk patients, despite a higher age, we have been able to reduce the length of stay in selected patients, of course, but also reducing mortality, stroke, cardiac readmissions, the need for pacemaker implant, and so on. So this 3M approach is still based on a good assessment of the patient before the procedure itself, but also during the procedure, thanks to CT fluoroscopy fusion technologies. But also it still needs the manipulation of guides, wires, and catheters to achieve aortic root angiography, hemodynamics, parameters assessment, aortic regurg index calculation, and sometimes immediate post-procedure TTE. This is something we want to eliminate now. And the only way to eliminate it is to go in the direction of non-invasive hemodynamic monitoring, as shown by these two recent studies. The study from Ristali showed that hemodynamic monitoring can be fast and easy method to optimize procedural results during TAVI. And this is why OpSens have been taking this challenge very seriously, and they have developed the first Guidewire in the world that helps you not only delivering the valve, but also allowing continuous hemodynamic pressure and gradients measurements, helping reducing complications and saving time and money and getting away from other conventional need for monitoring systems. 3 Ps are to keep in your mind. This wire is stiff. It helps you positioning the valve. Because it's well positioned, you can implant any type of valves. And because it's well positioned, you can do pacing over the wire and avoid implanting temporary pacemaker wire. It is designed to monitor continuously the pressures in the left, in the ascending aorta, but also in the left ventricle. It helps you assessing the gradients, but also any aortic regurgitation or paravalvular leak, and helps you making the appropriate decision and optimizing, fine-tuning the results at the end. This can be used in patients under general anesthesia, for example, when you go for alternative access, but also patients with moderate sedation, where it has been shown that outcomes are much more favorable than general anesthesia, but also if you want to go in the direction of pure local anesthesia. So my take-home messages are the following. Minimalistic TAVR can be performed successfully in most patients. The multimodality approach is the way to go and is the way to optimize the procedure and the post-operative course in low-risk patients, but also in all patients in general. A multidisciplinary approach is necessary and should be based on heart team approach. Again, the target is to deliver the best service to the patient. but that means it should not sacrifice the valve functionality assessment and hemodynamic monitoring. And today, Guidewire is the only wire to allow us to go into this direction. Thank you very much.